Thank you very much for having me. Let's see. While the slides are getting on, I think I really like the question from Dr. Ali earlier is, do we really understand the cardiogenic shock? And I think that's our main problem as an interventional cardiologist, because I'm the one who is going to treat that sick patient. And we, as a plumber, I must confess that we barely understand the hemodynamics of these complex populations, really. So whenever the slides are ready, you can put it on, please. Yeah. So
can we get the slides, please?
So today the talk will be mainly focusing on the right ventricle and the hemodynamics. How can it guide us to make some critical decisions about these critical patients?
Audiovisual, can we get the slides on?
5 minutes will be on that.
Yeah, okay.
Yeah, I think so.
You have 6 minutes, don't worry.
6 minutes?
You can do it.
4 minutes. Yeah. Okay, we'll try our best. I don't think we'll be able to that quick, but anyway. So the forgotten chamber of the heart. We're going to talk about how hemodynamics can guide us to treat some of these critical patients, and what do we need as a tool in our cath lab as interventionists. So I'm going to skip on some of these slides because in the interest of time, but 2 as 1, not 2 in 1. And we were usually taught about ventricles, that if there are 2 separate entities, but if you look at the anatomy and physiology, they are 2 connected chambers. And actually they share a wall between them as well. And that wall works for both. And if you look at the complex nature of the anatomical nature of the RV, then it's really strongly connected to the left ventricle, and the left ventricle automatically depends on the right as well. So it's all about biventricular performance and not univentricular performance. And harmonious biventricular performance means that left ventricular dysfunction in RV failure, how does it work? And how does RV dysfunction happens in LV failure? And ventricular interdependence is a misnomer which we usually hear. They never were independent of each other. So it's quite ironic that such a fundamental anatomical and physiological intuition was ignored. And conventional teaching was if they were totally independent pumps. So RV interferes with the LV, as we see in pulmonary hypertension, and as we see in pulsus paradoxus, that how does it affect the left ventricle filling. So if we look at at this complex slide, which usually you'll see that when we get chronic heart failure and RV dysfunction, the cardiac output goes down, but the PA pressure gradually starts getting down. It doesn't get better, but it's getting down because the PVR is getting up, and that's a failing right ventricle. Now, how does it happen? And we all know how does it happen. So increasing the pulmonary capillary wedge pressure will lead to RV dysfunction eventually. So shock in the right ventricle. So cardiogenic shock, by definition, is defined as cardiogenic disorder resulting in sustained tissue hypoperfusion as identified through clinical signs, biochemical markers, but usually associated with severe hypotension. And in hemodynamic terms, it's the cardiogenic shock, the cardiac index should be less than 2.2. And as we know, the mortality is very high. But we forget about this one because in a lot of these patients, as we see that 14% of these cardiogenic shock patients had RV failure, and they're not going to get better if you only concentrate on the left ventricle and ignore the right. So how do we grade the RV dysfunction in hemodynamic terms quickly in the cath lab? So if you look at the CVP, it will be high in the RV dysfunction, severe RV dysfunction. CVP versus wedge, like right atrial to wedge ratio will be more than 0.8 because the higher the right atrial pressure is and the lower the wedge pressure is, that shows the RV dysfunction. In PAPI, which is the pulmonary artery pulsatility index, is less than 1. We'll talk about that, and the RV stroke work index as well. These are very easily calculatable in our cath lab. So the relevant concepts as we go along, I'm going to skip some of these slides because they were absolutely very key slides. I wish we had time to explain them and to go through them. But in terms of hemodynamics measurements, is an operator there, I need to know the thermodilution and the FIC calculations, what are the pros and cons and what can interfere, and how can I can I get a best cardiac output measurement for that patient? So the cardiac output, how strong the heart can work, is the cardiac output, power output. And that's very important. That's calculated in watts. And again, I'm going to skip over it because of the in the interest of time to finish for the next session. But I wish we had more time to talk about it for a minute. The RAP and the PAC ratios, as we talked earlier about, it's strongly linked to mortality as well. In the PAPI, which I'm going to spend more 2 seconds on it, PAPI, what does it show is if the right ventricle can generate a big pulse pressure in the pulmonary artery and the right atrial pressure is low, that's not a bad right ventricle. But if the right atrial pressure is high and the pulse pressure in the pulmonary artery is low, that means that right ventricle may not be good. Okay, so we can talk about stroke work and the RV stroke work. If you look at the second one, the RV stroke work, that really tells us when a patient should not have an LVAD alone. And also, it should be less than, if it's less than 15, and if it's less than 10, then that's a bad sign in these patients, in the acute cardiogenic shock patients. So how hemodynamics can, in subtypes of cardiogenic shock can help us. So this is a quick slide, and if you can memorize that somehow, is the lower, as we say, the right atrial pressure, and the, if you look at the first one, in the RV dominant only, I'm going to talk about only the RV dominant shock. So in these RV dominant shock, we should have a high CVP, we should have a lower wedge, and we should have a RA wedge ratio more than 0.86, and RV and the PAPI should be less than 1.5, and the RV stroke index should be less than 0.3 in these patients.
Dr. Khan,
Yes.
sorry, we bitten from your time. We have 1 minute.
Okay, in that case, I'm going to go straight to the last slide, and that is this. So why we have poorer outcome, and that's action too late, action unscientific, and incomplete assessment, and using the same treatment for all, ignoring the right ventricle, and not utilizing all available resources in a timely fashion. Okay, and that's my conclusion. Thank you.